Good afternoon. Today I am here to deliver a talk on CT of pancreatic tumors. I am Dr. Samir Khan. I work in UK as a consultant radiologist, and I am also honorary clinical senior lecturer at the University College London. So the topic for today is CT of pancreatic tumor. Pancreatic tumors can be divided into solid and cystic types, and we can further subdivide them according to their behavior, as in their histology. Can they be benign or malignant? So the most common pancreatic tumor is pancreatic carcinoma, which is more than 90% of tumors which we see in clinical practice. Other than that, another solid tumor is pancreatic neuroendocrine neoplasm, which can have benign as well as malignant behavior. As far as cystic tumors are concerned, the first cystic tumor is serous cystic neoplasm, and they have got a benign character. Second cystic tumor, which we will learn about today, is mucinous cystic neoplasm. Mucinous cystic neoplasm can be benign, but they can degenerate into malignant histology. So mucinous cyst adenoma can convert to a mucinous cyst adenocarcinoma. Next cystic tumor is intraductal papillary mucinous neoplasm, which has got similar characteristics with a spectrum from benign to malignant. And finally, I will also be discussing this rare tumor, which is known as solid pseudopapillary neoplasm. Please note that in clinical practice, the most common cystic lesion, not a tumor, but a lesion which we see is a pseudocyst. I will not be discussing pseudocyst in detail today, but just to mention it, that pseudocysts are seen as a complication of acute pancreatitis, usually 4 to 6 weeks after the episode. So the clinical history is very important to diagnose that. Otherwise, pseudocysts usually do not enhance, and they are not septated. If a pseudocyst enhances, it might be infected. Within a pseudocyst, you might find debris. Again, it does not enhance. And please also note that second so-called cystic tumor might actually be a solid pancreatic carcinoma with necrosis. So some of the tumors, because of necrosis, do appear as cystic. Right. So we start with pancreatic carcinoma and a few key facts about it. The predisposing factors include chronic pancreatitis, diabetes, and smoking. At presentation, 85% of patients have incurable disease. Patients will have liver metastasis, 40% have nodal metastasis or peritoneal implants. At laparotomy, further 50% are found to be inoperable. This is so because of low sensitivity of CT to pick up small peritoneal implants, and that's why many surgeons these days are routinely performing laparoscopy before surgery, just for staging and diagnosis of such implants. So ultimately, only 7% of the patients have radical surgery, and the 5-year survival is only 10%. Here is a case of pancreatic carcinoma, where you can see that the pancreatic duct is dilated here, and the lesion itself is in this region at the head and the uncinate process. It is also causing CBD dilatation, which we can see here. Now, point to remember is that pancreatic carcinomas, the general behavior is that they are hypovascular tumors. So they enhance less than the parenchyma, and they will appear hypodense as compared to the parenchyma. A very important CT sign I want to elaborate here, and this is what we call duct cutoff sign. Whenever you see a dilated pancreatic duct without any perceptible mass, always think that there might be a carcinoma sitting there which we are unable to see because of the sensitivity of CT to pick up small lesions. In these types of cases, we can perform what we call pancreatic protocol CT, in which, other than non-enhanced, we perform a pancreatic phase and then a hepatic phase. Pancreatic phase is slightly different than arterial phase. In pancreatic phase, this is performed 50 to 55% delay. Here the enhancement of the pancreas is maximum, so the tumor appears hypodense and the sensitivity increases. Having said that, CT is not considered the gold standard here, and EUS is the best modality to pick up a small tumor. The sensitivity of CT versus EUS, you can see that generally speaking CT is 86% while EUS is 98%. But this difference becomes more marked if the tumor is small. So if the tumor is less than 2.5 centimeter, then CT has got a sensitivity of 53% while EUS has 89%. Here is an example. You can see that the pancreatic duct is dilated. The lesion is not well seen on the CT, while we can see it much better on the EUS. Right. So, role of radiologist in management of pancreatic carcinoma is not just for diagnosis. Our important role is to guide our surgical colleagues about the management. Is the patient a candidate for surgery or not? For that, we have to learn the basic concepts about pancreatic carcinoma. This is the T and M staging, and we are interested in the T staging here according to the latest AJCC. We can see that a T1 tumor is when the tumor is seen within the pancreas and it is less than 2 centimeter in size. A T2 tumor is within pancreas but more than 2 centimeter. T3 tumor, this extends beyond pancreas, for example, into duodenum, stomach, colon, spleen. While a T4 tumor is a tumor which involves the celiac artery or the SMA. Now this is important because encasement of celiac artery or SMA makes the tumor inoperable, and our duty as a radiologist is to highlight this fact to our surgical colleagues. If you want to take it further, let's see what treatment is done for a standard pancreatic head carcinoma. In operable cases, we do a Whipple's procedure. And in Whipple's procedure, what is done is that the head of pancreas and the tumor along with the duodenum is removed. And then a pancreatojejunostomy is performed. With that, a choledochojejunostomy and a gastrojejunostomy is also combined. So from here, what we have learned is that invasion of the duodenum, for example, is not an issue because duodenum automatically is removed in Whipple's procedure. A few examples from a few pictures. Now here you can see that there is a tumor here which is in the head of the pancreas. It is more than 2 centimeters, but it is resectable. This is a T3 tumor which actually extends into the duodenum. But even as we have just elaborated, it still becomes or remains a resectable tumor. This is what we call a borderline resectable tumor. Now this time the tumor is sitting at the body of the pancreas. It is invading the splenic artery. So in this kind of lesion, it all depends how fit the patient is, etc. We can remove the pancreas and the tumor, and we can also we can do a splenectomy. So this remains a borderline tumor. Another borderline resectable tumor, and this time what is happening? There is invasion of the superior mesenteric vein. Historically, these kinds of tumors were considered inoperable, but then surgeons have developed skills where what they do is they remove the tumor, they remove this part of the vein, and they use a graft, a jugular vein graft, to fill up the gap. So this is what we call a borderline resectable tumor. This tumor, on the other hand, becomes unresectable. Here what is happening, that the tumor is invading the duodenum, it is also invading the superior mesenteric vein. This does not change anything, but the main point to remember is that there is invasion or encasement of the SMA. So this becomes an inoperable tumor. Another example of an inoperable tumor which invades the celiac artery. So a recap of what we have learned about operability of pancreatic carcinomas. If duodenum or spleen is involved, this is operable. If SMA, superior mesenteric artery or celiac artery is involved, then it is inoperable. And there can be various borderline tumors, for example, SMV and portal vein, splenic artery as in this case, or stomach and colon if they are involved. So what is the CT criteria to say if a vessel is invaded or encased or not? Basically, we have got this principle of less than 180 degree involvement or more than 180 degree involvement. So what we have to look for is the interface between the tumor and the vessel. So here, if you see here, this is the tumor which is hypodense, and this tumor is touching this vessel for less than 180 degree in this case. Again, it is less than 180 degree in this case. So here we will say that on CT criteria it is not invading. On the other hand, more than 180 degree, like in this case or in this case, where actually there is 360 degree rim of tumor around the pancreas, around the vessel, these we will say that the vessel is invaded. There are a few other signs of similar vascular involvement. For example, there is flattening of a vessel here, flattening of a vessel here, and then there is tumor thrombus which is going into the vessel. So all of these are also considered signs of invasion. Let's see this example. Here you can see that there is dilatation of the pancreatic duct, and there is a tumor here which is slightly hypodense as compared to the parenchyma, not very clear. But the main point to remember is this thing on this coronal sequence. You can see that this is SMV, and there is indentation on the SMV the superior mesenteric vein due to the tumor. So we can say in our report that SMV is involved. Now, there is an example of arterial invasion by the tumor, and you can see that this is celiac artery, and there is a tumor which is surrounding it completely. So this is completely involving the celiac artery. This case, this is the SMA, and the tumor is actually encasing the SMA. Right. So after pancreatic carcinoma, we come to neuroendocrine neoplasm. And here you can see that there is a lesion which enhances on arterial phase. So this is a hypervascular tumor. And when you see a hypervascular tumor, we consider it to be pancreatic neuroendocrine neoplasm. Pancreatic neuroendocrine neoplasm are tumors which arise from the endocrine glands of the pancreas, namely from the islet cells. And they can be hyperfunctioning, so they can be endocrine active, or they might not be endocrine active. And they can produce various kinds of hormones which include and the tumor is named according to the hormones which it's produced, which you can see in this table. Point to remember is that all of these tumors, if you look at this right side of this column, can have malignant potential. And some of these, for example, insulinoma here, 10% of insulinomas are malignant, while this one, which is ACTH-HOMA, is 100% malignant. So we should consider a neuroendocrine tumor as a malignant tumor whenever we see it on imaging, and we should take it out. Now, the most important or most common neuroendocrine tumors include insulinoma and gastrinoma. Insulinomas can be part of multiple endocrine neoplasia syndrome 1, what we call MEN1 syndrome. And as I've already elaborated, that 10% of them are malignant. The second most common neuroendocrine tumor is gastrinoma. They can be multiple in 60% of cases. So that's a very important point to remember. When you pick up one tumor, don't just stop there, keep looking for further lesions. Again, they can be part of the MEN1 syndrome, but very important point to remember is that about 15% of them are extra-pancreatic in an area we call as gastrinoma triangle. I'll come back to gastrinoma triangle in my next slide, but I want to elaborate once again that about 60 to 65% of gastrinomas are malignant. So this picture tells you gastrinoma triangle, and indirectly it tells you that the lesion can be within the pancreas, it can be within the pancreatoduodenal groove, it can be within the duodenum or outside in all of this territory. This is a case of Zollinger-Ellison syndrome, and if you see here, there is an enhancing lesion at the head of the pancreas. This is well seen on this sagittal sequence, and this lesion is associated with hypervascular metastasis. If you see here, this metastasis shows washout here, and then you see this rugal thickening of the stomach. So this is Zollinger-Ellison syndrome due to a gastrinoma. Right. So now, after finishing the solid tumors, we come to serous cystic neoplasm. Now, look at this tumor, and this one is made up of many small cysts. So this is a classical serous cystic neoplasm. This picture tells you that a classical serous cystic neoplasm is like sponge-like or honeycomb-like. And another point, this is another example, is that sometimes these lesions have got a central scar. This central scar is important to remember because at times it can show calcification, and which becomes quite a pathognomic sign of this tumor. So, regarding serous cystic neoplasm, it is a slowly growing benign lesion. So please remember, it is considered a benign lesion without any without any malignant potential. 75% of these are seen in women, and the mean age is 62 years. Classical picture is sponge-like or honeycomb-like, as was elaborated in the previous slide. They have got a lobulated outline. Now this is an important sign to remember. If you look carefully and try to see the outline where I am elaborating, or try to see the outline here on another example, you will appreciate that this is lobulated. Why is it lobulated? It is lobulated because there are small cysts which are sitting underneath the outer wall, and which give them this lobulated outline. Please remember that on a CT scan, we might not see the cyst in each and every case. Actually, these are better seen on MRCP. But having said that, if you don't have MR to confirm your findings, you can still pick up this lobulated outline and infer from that the lesion is microcystic. Central calcification, as seen in this case, can be seen in 18% of cases. And you remember, this is because of the scar, the central scar. Sometimes serous cystic neoplasm can be oligocystic, and this is seen in 10% of cases. So oligocystic means that they have got larger cysts, and indirectly it is very difficult to discriminate them from mucinous cystic neoplasm, which we will learn about shortly. So what is the management of serous cystic neoplasm? If the lesion is small, then we can just sit on it and advise follow-up. But this also depends on the size of the lesion. And if the lesion is more than 4 centimeter, depending on the age and clinical presentation and location of the lesion, we might like to take it out. Right, so next lesion is mucinous cystic neoplasm. Now, mucinous cystic neoplasm is a spectrum. So there is a benign spectrum which is known as an adenoma, but then there is a concept of malignant degeneration, and the lesion can degenerate into a carcinoma. This tumor is exclusively seen in middle-aged women. Mean age is 47 years. So this is an exclusive female tumor. Now classically, these lesions will be unilocular, like our lesion here, unilocular. They can also be multilocular, but the cyst will be bigger in size as what we see in a serous cyst adenoma. There can be internal septations, they can be round or oval, they can be at times quite large, usually 6 to 10 centimeter. Tail and body is the most common site. They have got a smooth outline, unlikely the serous tumors which had a lobulated outline. Now look at this outline of this tumor and you will appreciate that this is smooth and sharp. These lesions can demonstrate calcifications in about 25% of cases. So you see here, there is calcification, and this is seen in about 25% cases. What are the signs of malignancy? Well, there can be wall thickening, or wall irregularity or mural nodules. These are the signs of malignancy. And what is the management? All of them are removed. So this is an example of a mucinous cyst adenocarcinoma, and in this case you can see that there are multiple cysts. Some of them are enhancing, and there is a bit of mural thickening and nodules inside the lesion. Another case of mucinous cyst adenocarcinoma. This lesion was initially misinterpreted as a pseudocyst, and a follow-up scan was advised. And unfortunately, at that time it was realized that this is actually a cyst. By the way, there was no history of acute pancreatitis, but there are other signs here which do not represent a pseudocyst. For example, there is an internal septation here, and the wall enhances, this septation enhances. But if you look carefully, you can see that there is soft tissue here, which is soft tissue of tumor, which is encasing the celiac artery and invading the portal vein. So this is a mucinous cyst adenocarcinoma. Right, then we come to the next variety of cystic lesions of the pancreas, and this is intraductal papillary mucinous neoplasm. And you can see it is causing this gross dilatation of the main pancreatic duct, and this dilatation extends all the way to the ampulla. And if you are a gastroenterologist and if you do endoscopy, at times what you will see is that mucin will be bulging out from the papilla like this. So intraductal papillary mucinous neoplasm have got a spectrum, and they can be benign and they can also convert into malignant histology. Usually they are male, and average is 65 years. So this is different from other cystic lesions of the pancreas, which were always seen more commonly in females. And the classification wise, these are three types. They can be main duct type, they can be branch duct type, and they can be combined or mixed duct type of intraductal papillary mucinous neoplasms. These pictures tell you the various patterns which we can see. So this is main duct type of IPMN. This one is a mixed duct type. So the main duct is dilated and you can see this bulging papilla here, and with that the branch ducts are also involved. These two are two different morphological varieties of branch duct type IPMN. And please remember, by definition, in these lesions there should be communication of the cyst with each other or the main duct. But on a CT scan you might not pick up the communication very well. In this regard, MRCP is much better than CT scan. A few examples. Now this is a branch duct type IPMN. You can see this small cystic lesion here and here. So this is branch duct type IPMN. This, on the other hand, is a mixed duct type IPMN. You can see this cyst, this cyst, this cyst, and then you can see that the main duct is also dilated. So this is combined duct type or mixed duct type IPMN. So what is the management of IPMN? Well, the concept is that risk of malignancy in main duct type is 57 to 92%, and in branch duct type it is 6 to 46%. What are the signs of malignancy? Well, the signs of malignancies which have been given in literature include pancreatic duct which is dilated to more than 9 millimeter, if there are any enhancing mural nodules, or if there are frank signs of invasion. So, management wise, generally speaking, main duct type lesions, we advise surgery. Of course, it depends on the age and the clinical scenario also, but generally speaking, we should not sit on this tumor because of the risk of malignancy. However, in branch duct type, we can advise follow-up as 80% of them remain stable. Here is an example of the main duct type of IPMN with malignant degeneration. So here is a hypodense lesion, and which is also causing obstruction of the CBD. Right, and the last cystic lesion is a rare lesion, but I wanted to highlight it here because of the clinical presentation. It becomes quite a pathognomic finding on a CT scan. This is known as solid pseudo-papillary neoplasm. Look at this patient. This patient is 26 years and has got pain epigastrium. So the point is that in a young female, if you see a cystic lesion, think about solid pseudo-papillary neoplasm. These tumors are extremely rare. Almost all of them can be seen in women. They are seen in young age group, 20 to 30 years. Average age is 24 years. This is a point to remember. They have got solid enhancing and cystic component. If you see here, in literature, some people have elaborated that this is hemangioma-like enhancement in the periphery, and then there is a cystic component. Sometimes these lesions also have got internal hemorrhage. Usually they are seen in body and tail of pancreas. They can be very large, up to 11 centimeters. By definition, they have got malignant histology, though they have got relatively indolent course, even with liver metastasis. 5-year survival is more than 95%. So just a recap of the ages to remember in cystic lesion. Please remember that most of these tumors are more commonly seen in females. And if you remember that concept, then serous cystic neoplasm is known as grandmother tumor because the average age of presentation is 62 years. So this is the grandmother tumor. A mucinous cystic neoplasm is a daughter tumor. Average age is 47 years. And then is the granddaughter tumor, which is solid pseudo-papillary neoplasm with average age of 24 years. Taking this concept further, we can also say that IPMN, on the other hand, is a grandfather tumor, usually more commonly seen in males, and the average age is 62 years. Right. Though it is not my mandate today to discuss the intricacies of how to manage incidental cystic pancreatic neoplasm, but I just want to introduce this subject to you. Please remember that many of these tumors, as we have learned in the presentation, are followed up. What are the guidelines about it? Unfortunately, there is no international consensus on this. So it all depends where you are working, and various people have got various protocols. I think a good reference which I have put for you here is from American College of Radiology guidelines. They divide. Please remember that these lesions, it is assumed that these patients are asymptomatic, because for symptomatic you might like to be more aggressive in your approach. Now they divide them into 3 categories: less than 2 centimeter, between 2 and 3 centimeter, and more than 3 centimeter. And the guidelines are, if the lesion is less than 2 centimeter, then you follow it up for 1 year, and if they remain stable, then there is no need of doing anything further. For this category, which is in between 2 and 3 centimeter, you have to do a further characterization. It is recommended to do an MRI or MRCP, and then you characterize them. If it comes out to be a serous cyst adenoma, you can follow it up for up to 2 years, every 2 years. If it is branch duct type, then you follow it up every 6 months for 2 years. And if it is uncharacterized, then you do yearly follow-up. Now the questions is yearly follow-up for till when and things like that. So many questions remain unanswered, and that's why I'm saying that there is no international complete consensus. Now the recommendation in this third group, where a lesion is more than 3 centimeter, are slightly different. If it is a serous cyst adenoma, particularly if it is more than 4 centimeter, then resection is considered. On the other hand, if the lesion is uncharacterizable, then you do cyst aspiration. And depending on comorbidities, etc., you can resect the lesion. So these are general guidelines which one can follow in such cases. Right, so in the end, a summary of what we have learned today. We have learned that pancreatic tumors can be solid as well as cystic. The solid tumors can be pancreatic carcinoma or pancreatic neuroendocrine neoplasm. Pancreatic carcinoma is the most common pancreatic tumor, and more than 90% of patients who present with pancreatic tumors actually have pancreatic carcinoma. Pancreatic neuroendocrine tumors can have benign and malignant potential. And as far as cystic lesions, we have learned 4 types of cystic lesions, which include serous cystic neoplasm, mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, and solid pseudo-papillary neoplasm. Serous cystic neoplasm has got a benign behavior. On the other hand, solid pseudo-papillary neoplasm has got a malignant behavior, though indolent in clinical course. But these two, which is mucinous cystic neoplasm as well as intraductal papillary mucinous neoplasm, can have a benign behavior, but then can degenerate into malignancy. So thank you very much for listening.